Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. I am really looking forward to my conversation with today's guest, Dr. Kevin Boyd, or Kev, as many know him. Dr. Boyd is a board-certified pediatric dentist practicing in Chicago. He holds a Master of Science degree in Human Nutrition and Dietetics, and we're going to discuss that and how that has impacted his understanding of malocclusion much more in today's episode. He teaches in the Pediatric Dentistry Residency Training Program at Lurie Children's Hospital and also serves as a dental consultant to the Lurie Sleep Medicine Service. Dr. Boyd is an adjunct assistant professor in the Department of Anthropology at the University of Arkansas, where he mentors PhD research. And he serves as a visiting consulting scholar at the University of Pennsylvania's Museum of Archaeology and Anthropology, where he is collaboratively exploring a hypothetical relationship between changed dietary practices since the Industrial Revolution and diminished human dentofacial development. And again, we're going to touch on many of these concepts during today's episode. Dr. Boyd also lectures worldwide on the topics of early childhood malocclusion, pediatric sleep breathing hygiene, and evolutionary oral medicine. So with that very impressive background, I want to extend a sincere welcome to the amazing and inspiring Dr. Kevin Boyd. Welcome to the Doc Podcast, Kevin.
Thanks, Mike. I'm really honored to be here. Thanks for inviting me.
I kind of like to start, Kev, by just getting into a little bit. I want to give you some recognition first. I'm sure many of the people listening know of you, have heard of you, and many have learned from you. And I just want to recognize you for what you have done for the profession as a whole, all the patients that around the world that have benefited because of the time, energy, and dedication that you've given to helping expand the knowledge of your colleagues. And I just want that, I don't want that to go unrecognized, because we're going to have an amazing, awesome conversation in a lot of different directions we're going to explore today. But before we do that, I think everyone, even if they don't know you, should know that as I was getting into this teaching and podcasting side, the name that kept coming up as somebody who not only someone I had to speak with, but also someone who was a mentor and a real inspiration to them was Dr. Kevin Boyd. So thank you for all you've done.
I'm glad the protocol is getting recognized. I mean, it does my ego good, everything you were saying, but I'm just the visibility that this is getting and the attention. And now, it's just like if you and I and others can arouse curiosity in our colleagues and remember where we were before we knew this. It's so easy to be judgmental. Like, what does it matter with these people? And it's like, well, where were you 10 years ago, Mike or Kev? I mean, look in the mirror and try to be less judgmental. And, I think what you're doing with your podcast is not only arousing curiosity, but you're generating not so much debate, but what I call, and I had to learn this whole concept from the debate, industry, is that dialectic. It's a form of discourse that really wants to bring about constructive dialogue and not I'm right and you're wrong.
Yep.
And so that's really, I think, what you're doing and what I'm trying to do. And so let's try to do it together here. Let's generate some curiosity and discussion.
Let's do it. Yeah, I am really excited to have this discussion with you today and share it with the audience. So if you don't mind to start out, just kind of talk a little bit about, for those who maybe aren't familiar with what we're talking about, or when I say you've inspired and mentored numerous people, what are you doing that's different, unique, and how did that come to be? Is it something you were trained in? Is it something that evolved as you were practicing?
As we were talking about before we started, you trained at UConn, and I in the 80s was recruited to UConn by Brian Clarkson. He's a pediatric dentist, just a top scientific clinician, researcher. Cardiology was his deal, and that was my deal in dental school. I studied cardiology and met him at a research meeting by the ADA, when I was still in dental school. And that's really what the other thing that brought me to the University of Iowa to do my pedo fellowship in 86,
Okay.
88 was not just cardiology research, but they were doing early orthodontic dentofacial orthopedic treatment. It was kind of known for it at the time that you would get this, and you'll be treating very early, very aggressively, under 9 years old, which is a geriatric patient to me now.
Mhm.
But it was still considered heretical, and they were doing functional appliances, and the ortho department wasn't doing that. And so I first got exposed, to the disparity between orthodontic departments and pediatric dentistry
So this was
departments.
happening in the pediatric department, you're
Oh,
saying?
yeah.
Okay. Okay.
And I took my cephalometrics and growth and development with the orthodontic residents. Sam Bashara.
I'll say it was a Bashara. Yeah. Yeah.
Yeah, he taught us, cephalometrics and growth and development. And
Yep.
he wasn't talking about airway back then.
Yep.
So I think that's what started the whole thing, where I was just really curious and wanting to intervene as early as possible. I mean, you wouldn't ever criticize somebody for intervening on a white spot lesion very early before it's really a cavity.
Right.
But it's like, well, that the malocclusion distal step, Bashara taught us this, a distal step molar 100% of the time will become a class 2.
Class 2. Yeah.
Always, but they weren't talking about airway or, systemic comorbidities with mouth or anything like that. So just wait, till they're older, and, so it was. But now the pedo department, 8, 9 years old, I think you can get in there.
Interesting. Was there friction between the two? Was it adversarial?
Oh, friction isn't the word. It was warfare.
I guess.
Dr. Casco and Dr. Clem Full, rest in peace. He was the pediatric dentist that really brought orthodontic dentofacial orthopedics into the pedo department. Way back in the late 70s, early 80s, he was pushing for this. And but it was, so what? We still, Andreessen, the guy who invented NiTi, he taught us how to bend wires.
Yeah.
And I told you, I had exposure to some really excellent orthodontic education.
Wow.
As a pediatric dentist, but I also got hundreds of hours of, clinical opportunities and didactic training and behavior guidance and child development. Jimmy Pinkham, our director, had a PhD in child development. Figure that was a big part. And we really didn't have to take a lot of courses, Mike.
Yep.
It was they called it andragogy. It was self-paced. We had to do 24 learning objectives. So, for the statistics, we did take a stats course. I got out of it because I had a master's going into it. But we could do independently a program on behavior guidance, and I could get a professor at the University of Iowa's, child psychology department and follow them for 2 weeks and write up a paper. And that was my requirement. So it was a great, great, great program. I don't think they do it that way anymore, but it was excellent. I had a great experience at Iowa.
That's phenomenal. So after you went through that, did you go into practice right away and carry that over, or did it take you time to start to implement those techniques?
Great. Yeah, great question. I thought I was going to be a full-time academic.
Okay.
Because I had a graduate degree going into dental school, and I did research, had a few abstracts published and things like that. So I worked part-time downtown Chicago with Mary Hayes, one of the leading pediatric dentists in Chicago. I think she's retired now, but she took me on part-time and actually made it easy for me to get interviewed for an academic position at the University of Illinois, where she was on staff, and Rush Presbyterian, where she's a clinical instructor. And I was teaching half-time and practicing half-time and, really liking it. And then I got recruited to the University of Chicago into a faculty practice that, it did ortho and pedo, and I got to interact in bone marrow transplant and just doing all kinds of things. It was very exciting. I had a joint appointment in the Department of Pediatrics and in surgery, where dentistry was. And we had GPRs and oral surgery residents and oral and maxillofacial prosthetic residents. And it was really, really exciting. And I was in the faculty practice, and it got huge to where the demand, because I was doing early treatment, and I actually was in charge of getting an orthodontist to join the practice, and we sort of collaborated, but not always really amicably. But
Mm-hmm.
know what, it worked. Dr. Neil Wachowski, great orthodontist in Chicago. We're still, friends and colleagues, but don't necessarily agree with each other and everything.
Mm-hmm.
So that was just how it all started. And then I just got recruited to Children's Memorial Hospital from there. And I kept the appointment at U of C and was teaching. And then the pedo residency I got to teach in. And then I moved my faculty practice from U of C to a private practice in downtown Chicago near Children's Memorial. And then I'm severely part-time now in academics.
Yeah.
I'm still working, 4 days a week and seeing 30, 40 patients. And I have two what we call primary care general dentist colleagues. One's been with
Mm-hmm.
me for 23 years, Janet Panarella, does all the same ortho that I do. And she's really picked up a lot of the pedo restorative that allows me to focus more on the ortho.
Mm-hmm.
And we're trying to bring in another pediatric dentist into the practice now. So yeah, is that it? There's my history.
Yeah, no, that's awesome. I love learning about I think it's so fascinating, and I feel really important and relevant to hear the journey of what got us all to where we are. Because I think a lot of times, especially younger docs, will see a more senior doc and they'll see somebody who's been doing this and they're like, oh, they just, this is what they do or this is who they are. But it's a journey, and that journey led you to where you are, and all those experiences that you've had from going back towards maybe going to UConn and being involved in the cardiology side and the research side, and then getting into that anthropological side and the behavioral sciences side at Iowa, and having some wire bending background and understanding the ortho side and performing early childhood treatment as a pediatric dental resident. That's so important, because unfortunately, I think a lot of my orthodontic colleagues, and I want to just start by saying, when I make comments that may seem negative about my orthodontic colleagues, I don't mean them in a negative, disparaging way. I love my profession. I love my colleagues. I love what I do and we do as a profession. That being said, I try to call balls and strikes and be fair on this, because I feel it really needs to have a fair and honest assessment. And I think anybody would be hard pressed to disagree with the statement that many orthodontists will hear of a pediatric dentist or a general dentist doing orthodontics, and it kind of ruffles their feathers a little bit. And that's what goes beyond the scope of today's show to talk about why that is. But I think it's really important to paint the picture for people that you have a background in this. You understand this, and you understand this at a level that many orthodontists don't. And that's the behavioral sciences side. So talk a minute about that, if you would, more about, as you learned about the behavioral sciences side, what you were learning and how that started to shape your understanding of the etiology of malocclusion.
Well, you said one thing. Maybe it's beyond the scope of this conversation, Mike, but I think you just led right into it. I think it's very much a part of this. I think the fact, again, as a program director, which I did at UCLA for a while, I commuted from Chicago, to California, and did that for
Wow.
about a year and a half. And I had to really know the CODA, Commission on Dental
Mm-hmm.
Accreditation, so we'd get accredited, and I had to know the ortho and the pedo curriculum pretty
Mm-hmm.
well. And it's just, when looking at the ortho curriculum, there's absolutely no requirement for pediatric behavior guidance.
Right,
There's just,
right,
and it's like that. The implication is, why would you need to know how to manage anxiety in a 4-year-old?
right,
I mean, you not only will you not be doing that, you shouldn't be doing that. That's
right. That's the pediatric dentist job. We don't want to deal with that. Right,
it is. So,
right.
and so I think it's incumbent upon, like, your listeners, even somebody who might be tuning in that's not experienced, or maybe they're in academics or not. But if you're a resident in ortho, and there's a pedo program nearby or in a university setting, it's okay for you to say to your faculty or director, look, could I'm ahead of my, requirements here, or can I go sit in, in a pedal lecture on behavior guidance, or can I go watch how they manage anxiety in children?
Mm-hmm.
You can do that. When I was in dental school, I started a pedal club, if you will.
Interesting.
I had, I was a pretty go-getter there, and I got like-minded undergraduate dental students from freshmen to seniors, and we would meet quarterly, and we'd have meetings, and
Hmm.
you can do stuff like that. Just ask your directors, look, I just want to see how this works. So I think it's just it isn't, you can't just say, oh, my curriculum didn't have it, or my director didn't. They're, just go up and ask, can I learn about this?
Yeah.
So I don't know.
Yeah, and it's interesting you say that, because I've said before on this show, and I've said this in lectures I give, that I went to Stony Brook for my dental schooling and my pre-doc, and we had a gentleman there who I believe is still there. Do you know Fred Ferguson at all? Do you know of
I've
Fred?
heard you talk about Fred Ferguson before.
He
I looked him
run.
up after he sounded like him. Is he? Yeah, he sounds like I'd love to meet him.
Oh, I still say, I'm like, I've got to reach out. I
Yeah,
haven't spoken to him since I graduated, but I really think I've got to reach out to him to try to get him on the show and talk to him and
you
give
really
him
should. Yeah.
the credit he deserves, because we had a really intense program in pre-doc. He was a pedo instructor at that time, and I think he went on. They didn't have a pedo program when I was there. They went on to start one. I believe became the director, as he should have. So he was really big on teaching us how to manage patients with special needs, even if they weren't younger kids. Their behavioral age was younger, and he was unrelenting and in a positive way. And you're a dental student, you don't really know. I mean, it's scary when some patients start screaming and yelling and flailing, and he was everything. And he was really big on not just medically sedating these kids, but understanding how to manage them. And I honestly don't think, if I hadn't had that training, I would have been as confident or comfortable starting to treat younger and younger kids in my practice, because I knew how to talk to them. Even the things I don't have to tell you or any of the pediatric dentists watching, but your body language, your voice tone, your connection with them, turning and facing them, starting to get their attention, de-escalating the fear, not combating them, all these things that he taught us that just became part of my background that I now was armed with as I went forward. I don't think I would have been able to do what I am successful in doing with younger kids. And I actually take time to teach the residents at Nova, where I teach a lot of these techniques and just how to do that. So you're so right. If you don't have exposure to that, and I don't think, I hear from a lot of people, laypersons who watch my content and follow the show, and I've had people reach out to me and say, I had no idea until I heard your show that orthodontists don't get trained in treating younger kids. And I would go so far as saying the majority of orthodontic residents out there will graduate from their orthodontic residency treating fewer than 10 kids under the age of 8 ever. Dental school, ortho, period. And that creates a fear in treating them, because if you're not familiar, and fear is based in our lack of familiarity, right? If we're not familiar with something, it creates anxiety. And the thought of going and treating these younger kids when you're not equipped with that skill set is one big obstacle. And the other big obstacle is orthodontists tend to run very busy, very hyper efficient practices that are predicated on seeing patients for shorter visits. Even their consultations are shorter sometimes than they should be. And it's about getting patients through the system, and kind of, you don't want a cog in that wheel. And it's really doesn't lend itself to seeing a 4-year-old or a 5-year-old in that day. It's a very different, not only skill set, but the systematization for that type of treatment and diagnostic approach is very different. So when you break it down like that, I think it's pretty easy to see why so many orthodontists are so resistant to it. And then the last thing I'll say, and I want to hear your thoughts on it, is when you aren't doing it and don't feel you're capable of doing it, it's kind of human nature to just be like, well, I don't really want any of my colleagues doing it, because then I look like the one that's not able to do it. So I don't want the other colleagues doing it. If you have questions about a clinical case, or maybe a challenging practice management issue, or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice, Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
That's huge what you just said. That is a really big deal, Mike. And this is why I remember the name Fred Ferguson, because you just reiterated pretty much what you had said. And it's like, because I really think that person changed your career, because it enabled you. You overcame the fear. And that's why I completely understand what you mean. Like, what if they won't open their mouth? Well, let's not even get to the next thing. There's a couple of things. I mean, Ferguson, please get him on, because
you've motivated me to move on.
He's
Yes,
responsible for changing the trajectory of your career.
Yeah.
And it's getting the protocol noticed. And it's, this, I mean, wow, I can't, he's an orthodontist, right?
No, pediatric dentist.
He's a pediatric dentist. Okay.
Yeah.
Oh,
he would stop clinic. I mean, you would hope it just wasn't you, because he would walk you always watching everybody and just such a coach of all of us. And, some people could stop clinic and we would be working on patients with special needs in the middle of something difficult. And he would be like, everybody stop what you're doing. And you're like, stop, and he'd like, leave, go, your assistant will stay with your patient. You come over here. I want you to see. So we'd all huddle around the bay of somebody who was doing something not correctly. And like I said, you just hoped it wasn't you that day. And, but he wouldn't embarrass the student. He would talk them through and have the other classmates, colleagues, right? A nice collegiate interaction, say, what are we seeing here that can be improved? What is happening that's causing this to happen? And I mean, the kid is flailing sometimes and he's so calm. And I swear he was like the patient whisperer. He would then step in and he'd say, I'm going to show you all how you do this. And he would sit, and all of a sudden this kid was like, still as could be, and open in the mouth. And we're all like, what in the world? But what he was doing is he was creating that connection in our brains of, this is what is going on that's not working, and this is how you do it. And it just started to become part of us. And I know from other dental school classmates of mine, many of us have practices, no matter what specialty we're in, where we treat younger patients, and a lot of times we would, because we're not scared of it. And that was, unbelievable.
That reminds me of Obi-Wan Kenobi. I mean, that, look and talk.
Yeah.
I was at Stony Brook undergrad. That wasn't in your ortho residency.
No, that was Stony Brook undergrad. Yeah.
If you remember that and brought that to, I mean, this is just, I could talk about this all day with you, but this really is so fascinating to me.
Yeah.
You're talking about I think the two things I would like to, like when I am talking to sometimes orthodontists, I get invited to ortho departments, believe it or not. And I do have a few orthodontists that, Kevin, I don't do this, but I know you do. So I'm sending you this patient. And it doesn't happen that often, but it does. When I lecture, I try to introduce a hypothetical situation to people. Okay, let's say unequivocally, who's going to argue if there's an anterior posterior crossbite, if there's a class 3, obviously maxillary hypoplasia, and the kid's 5, okay? Nobody's going to argue. It's in the literature. It's evidence-based, evidence-informed, if you will, maybe not prospective randomized blinded trials, but those are things that will not get better. They won't. They can't become comorbidities, or already are with sleep and breathing problems. Not always. They're comorbidities. Use that term instead of risk factors. And they're not going to go away, and they will respond to appropriate intervention. Well, you sit and you say to your class, say there's 10 orthodontists and pediatric dentists, maybe that have never done ortho, or primary care general dentists, and they're all in. Okay, imagine yourself that you've been referred, a kid with unequivocal need for dentofacial orthopedic orthodontic intervention. What if they won't open their mouth? And then you call on each person to say, what would you do if the kid won't open their mouth? Okay, get them to think about it. There isn't a right answer there. You want to hear how they think about it. An ER doc, if a kid comes up with a gash, what if they won't stop crying? Well, you got to cover the wound. Well, these are slower progressing chronic problems.
Yeah.
It's not necessarily a great analogy. Or what if it's nearsightedness? that doesn't go away. It always gets worse.
Right.
It's like something, and you don't wait till they're driving a car to give them glasses.
Right.
So I
Right. You
use
don't say,
those
I can't get the
analogies.
4-year-old to sit still in the eye exam. So we're just going to let them not see.
So let's talk. Let's talk about how you do it. And if
Right.
you're, if
Right.
you're not a pediatric dentist with formal training in it, if you're a parent, you can be retrofitted. The second thing I want to bring up is anthropology.
Mm.
Now, this is my background. And, I always, when I lecture, and I'm a broken record to some people because they've heard me talk, but it's like you got to lay down the tools,
Mm-hmm.
because I know most people in medical and dental healthcare professions, they don't get basics in anthropology and evolutionary biology.
Mm-hmm.
Humans, Homo sapiens, like us, our genome, have been around for 300,000 years.
Mm-hmm.
Okay, let's just accept that and Google it or do whatever you want, but it's a supportable hypothesis. But the science that supports it comes from something that isn't recognized as a basic life science by healthcare professionals. It's called anthropology and evolutionary biology. It's still controversial, and
Mm-hmm.
ever since Darwin it is.
Mm-hmm.
But there's a discipline in healthcare now. It's a framework. It's called evolutionary medicine. Well, I want to bring it to dentistry, evolutionary oral medicine. We need to look at things from an evolutionary perspective.
Mm-hmm.
Well, 300,000 years ago, you didn't survive childhood if you had something that would lead to an orofacial myofunctional disorder. That means that your mother died, or she could no longer lactate, or you got an infection, or eaten by a bear, whatever. To get out of childhood, you had to have had the ability to nurse and wean according to an ancestral pattern, which is on-demand breastfeeding for up to a year,
Mm-hmm.
and then weaning into the third year of life onto hard, minimally unprocessed, fresh, wild food.
Mm-hmm.
You had to be able to chew, you had to be able to suckle, or you did not live long enough to develop a malocclusion, much less survive childhood.
Mm-hmm.
Okay, so that's the basic. All right. So I think it's important also to know that hunter-gatherers, which we all were
Mm-hmm.
till about 10,000 years ago, when we discovered agriculture and started growing our own crops, okay, is that children of hunter-gatherers, they didn't get timeouts. They weren't punished. Okay. And we are, because they were hardwired to imitate the adult caregivers, the tribal elders, to please them, to make them happy. And that sounds like Dr. Ferguson.
Mm-hmm.
Is, look at, I'm going to ignore your bad behavior. In fact, you're going to reach in the fire and you're going to get a burn on your hand, and you're going to learn not to touch that. And you're going to play with each other, and you're going to teach each other, and you're going to do games. I don't go up to a kid and start, you got to do this.
Mm-hmm.
I know if I have parents coming preloaded, that they know my protocol, they know their neighbors or relatives' kids have been, I treat malocclusion, I don't treat apnea, I don't
Right.
treat
Right.
ADD, but those things often mitigate when you're treating them at their comorbidities.
Yep.
Parents come, and the child picks up on it that mom and dad trust this guy, and they want to be here. And people don't understand. A lot of parents have dental fear and they have anxiety, and they lay it on their kids, and the kids come in either, fearful or maybe not necessarily receptive to what we're going to do.
Yep.
So I have found, when I was sort of a free range pedo patient would come in 15 years ago, I'd start talking about bedwetting. They'd look at me like I'm from outer space. I thought you were a dentist. We came to get our teeth cleaned. And even when I first started, lecturing about it, people would walk out. What are you talking about bedwetting for? So, but my practice, because this is in the public domain now, and I lecture and people can pick up on it, and they have, referrals and my referrals are coming from other healthcare professionals, therapists, pediatricians, ENTs,
allergists.
So it's just that it's changed now. People come, and the kids, if they won't open their mouth, my first response is, Billy, you don't have to open your mouth here. Didn't mom and dad tell you? You don't have to do anything you don't want to do here. I'm going to leave. Here's a bike horn, and I'm going to go upstairs and take a nap. I have an old house as my dental.
I did too.
And when you change your mind and invite me to come, blow the horn and wake me up. I don't like getting up from a nap, but I'll come down and we can
Love
work.
it.
Oh my God, these kids and I say, if you don't want to do it, mom or dad can take another day off from work and you can miss school again or preschool and they can bring you back some other day. So but I'm not going to fight with you. Dr. Kemp doesn't fight with anybody. And that sounds like your guy, right?
Yep.
Comes from anthropology. In fact, I can give you a couple slides from anthropology textbooks that really talk about children are hardwired to please and imitate.
Oh, that'd be great. Yeah, I can link them in the show. If you give them to me, I can put them up.
Yeah, great.
Okay.
So that's kind of, I think, a couple pearls people can get. Even if you don't believe me, just try it sometime.
Yeah. Yeah. And the thing is the average dentist, especially orthodontist, is not equipped with that skill set or that knowledge. And it's not a criticism, it's a fact. And I've taught so many residents over the past 20 years, and they oftentimes just say when it comes to a younger kid, they're just not comfortable with it. And it's interesting because as orthodontists, we jumped into treating adult patients without a lot of data, without a lot of research. We jumped into Invisalign and plastic without a lot of data. There weren't any longitudinal randomized control trials before we started throwing plastic and attachments and doing more aggressive IPR on patients. Why? And this is just my hypothesis and theory. It's not a big stretch or leap when you can treat a 13-year-old to treat a 30-year-old, right? Like the behavioral management side, which is what you're talking about, really not that different. Sometimes easier because the 30-year-old sometimes just like, doc, just do it, get it over. Don't even, talk to me. And I just gonna sit here and close my eyes. And so it's not a big stretch. So I think we were much more accepting as orthodontists of it because it's like, oh, well, these are other patients who are in need, even though there wasn't a ton of research that we had to go in and fix this, 60-year-old's teeth that they've been working. Those teeth have been in their mouth essentially since, the full dentition, let's say at 12. So, 50-ish years they've had this dentition, and there's maybe there's not a significant breakdown and they just want some adjustment or aesthetic changes. I don't know where the research is that says that, that you can provide this huge benefit. Obviously there's some social implications and aesthetic implications, but again, we did it without requiring and demanding these randomized controlled trials over long periods of time. Why? Because we could do it, because we weren't scared of doing it. Right. I mean, clear braces, maybe the 80s-ish, it was plastic. And when you took them off, they break the enamel off with them because the bonding techniques weren't there. So we didn't really get I think, good at clear brackets until probably, I'd say, late 80s, early 90s. And when did you start to see adult care go up? When we had a way to deliver it that we could use and that the adults accepted. Well, why are we so resistant to going earlier? And I always say to people who say, oh, you don't have the data or the studies, I say, show me the data or the studies that say that you can't help a younger patient. Full disclosure, in my practice, I had never treated anybody prior to, I'd say 5, 6 was about the earliest. Not that I was opposed to it. I truthfully wasn't educated in doing it younger. I'm learning a lot more about that now. And I didn't get referrals at that age at that point either. So very comfortable, 5, 6, 7, we're going all the time on that age patient. But there are a lot of my colleagues who say, there's no need to go in on a patient that age. You wait, there's no need. But what do they tend to say, Kev, when they back that up? Kids can't tolerate treatment at that age. And that tends to be their biggest offense. And again, I've never heard, and if someone listening, watching, please send me documentation that there are studies that show that you can do harm. And as you alluded to before, some people are saying it's malpractice and outside the standard of care, which again, I think they need to understand the definition of standard of care, and I won't go into that, but it's not really an appropriate statement to say that anyway. But either way, show me the data that substantiate that comment that we shouldn't treat kids younger, right? You're calling for the fact that we have to prove we should, but we can prove empirically, and we can prove, the evidence that we're able to produce all these providers around the world that can show everything you do every day, everything I do, we can show that. And they can't show that this malocclusion self-resolves. They can't show. And the last thing I'll say about that, and then I want to turn it to you to hear your thoughts on those comments, excuse me, is when a lot of times when I talk to people about this, my orthodontic colleagues especially, or I'll hear them on another show or lecturing, they'll talk about the fact that malocclusion is entirely genetic and there is no environmental impact on malocclusion. And then they'll also, in the same breath, oftentimes say, well, of course, there's adenoid facies and digit habits, parafunctional habits, and those can have an impact. But by and large, it's really just you have a mom and you have a dad, and that's what determines the malocclusion. And I often say, you can't have it both ways. You can't say that, well, if their adenoids are large, sometimes they could have these things called adenoid facies that most of us just remember because we studied it for our boards. But they're a vertical grower because it's mom and dad and genetics. No. Can't be both ways. Either the environment's playing a role, and we know, Edward Engel talked about malocclusion, of all the causes of malocclusion, mouth being the most potent, constant, most varied in its results. Leroy Johnson in 1921 in the International Journal of Orthodontia talked about this with the face and the growth, and E.A. Bogue in the 19-teens, Melvin Moss in the functional matrix theory of the 60s, and Enloe, and speaking of the functional imbalance, there's all this evidence, yet they almost deny it and are like, nope, it's genetic. So with your anthropological background, please give us some of the data to substantiate or at least explain what causes malocclusion and why going in younger can be beneficial.
Well, if you start out with the fact that there's really no appreciable skeletal malocclusion in the ancient skeletal or fossil record, like zero. You can find a little in lower incisor crowding on Egyptian mummies, but their thirds are in and there's retromolar space behind it. And there are evidence recently, just recently, Mike, I found this paper. Somebody sent it to me. Well, what about this? And it was in 4000 BC or 3000 BC. And there was I think it was somewhere in Europe. It might have been France or Italy. But they uncovered this cemetery, and there was just a lot of anterior crowding, but also warping of the alveolus, mainly around the canines. But the thirds were fully erupted, and there was retromolar space behind them. And I'm very grateful that I have learned enough to actually be responded to when I inquire to three of the leading dental anthropologists in the world: Robert Corricini, Jerry Rose at Arkansas, emeritus. He's the one who hired me to mentor one of his PhD students as an adjunct, and Tim Bromage at New York University. Now, Tim Bromage, I'd like to talk about for a few minutes because you brought up Melvin Moss's functional matrix theory. And the first time I heard Bromage talk is with an orthodontist, Chris Simmons, I think his name. I don't know if he does ortho. But he asked the question, does anybody here, can you tell me what the functional matrix actually is? I'm not saying the functional matrix theory of Moss. Can anybody tell me, say, what is the functional matrix of the respiratory system? And not one hand went up. Okay, what about the masticatory system? What is the actual functional matrix? Not one hand went up. And then he went off for about 10 minutes and explained that the actual matrix, the functional matrix of the masticatory complex, food. It's food. Okay, now what was food for the first 290,000 years of human existence? It was hard, fresh, firm, fibrous. And you spent your entire waking existence, almost entire waking existence in pursuit of it, hunting and gathering. And the other time you're awake, you're chewing it. Okay? So you're processing it, cutting it off the carcass and chewing it. And then cooking came while you could, taste it a little better and you could chew it a little less hard, but it was still firm. What is the functional matrix of the nasorespiratory system? And he didn't say respiratory system. He said the nasorespiratory system. It's ambient air. That's it. That's what expands it and grows it.
Yep.
And when we were outdoors and not indoors, we were breathing fresh, clean air through our noses from birth. we took one breath through our mouth and the rest was all nasal breathing for your entire, less emergency air, junk food air through the mouth, right? So getting to the question, is it genetic? Is it epigenetic? Of course it's epigenetic. I mean, eye color is not really epigenetic. You got little b recessive, you're going to have blue eyes, right? I mean, it's just there's diseases. It's not one gene, one disease, except Huntington's or sickle cell or cystic fibrosis. Those are, one disease, one gene, but everything else is a combination of genes on the same chromosome interacting with other genes on other chromosomes in concert, acting with the internal environment of the individual, in concert, all interacting with the external environment. So of course, when people say, why do my kids have this? It's genetic, right? My husband and I both needed orthodontics, and he got it, I couldn't. Well, the answer I always give is, of course, it's genetic because we all have genes. Okay, but what do those genes do? How do they, express themselves? It's not they're not self-determining.
That great
Genes
point.
have to be told what to do. And there's different types of penetrance, genetic penetrance.
Sure.
Like long bones, that's somatic growth. Well, long bones, hypothetically, if a child is bedridden between birth and 18, they're going to grow to about 70% of their genetic potential for how long that those legs can get and the arms without really getting much stimulation, getting epigenetic muscular pressure, contraction and expansion. But it's still going to do that. Long bones do that. This doesn't do that. And again, the functional matrix. The brain is the functional matrix of the cranial vault. That appositional bone growth across the sutures, okay, that stops. The head circumference stops about 10, right? When the brain is like full. Well, how about what my mentor at the university at Penn, University of Pennsylvania, where Mariana Evans, who's a dual boarded perio-ortho, if you haven't had her on the podcast.
She and I have kind of played text tag and email tag. And so, she got to get her on.
She teaches a course for pediatric dentists. She'll let primary care dentists and orthodontists into it. But she opens up, she's a periodontist and an orthodontist, but she opens up, I'm not going to say a word about sleep and breathing. You guys wouldn't even be here. You wouldn't even be curious to come to this course if you didn't already understand that. I'm not going to rehash that. I'm going to talk about resistance to age-related periodontal disease. Another reason to expand the alveolus and the basal bone and separate the sutures under the age of 6. How come? So that those teeth will erupt into what she calls juicy cancellous bone. And the mucogingival junction is firmly in place. So that's yet another reason to treat early. So anyway, that's just a new thing. But when she and I started working together, and she arranged it for me to come to lecture to the ortho department, which when the ortho director got hold of it, that a pediatric dentist is going to talk to my residents over my dead body. So she arranged a whole separate thing and invited the ortho residents, the pedo residents, the anthropology, and to her office where it's a teaching facility. And we just, interacted. And Janet Monge is the PhD curator. She's temporarily on leave, but she's a brilliant PhD anthropologist who just loved what Mariana and I are doing in terms of the anthropologic theory and applying it in our practices. She called this, and she doesn't remember, like, did I say that, Kev? Well, okay, I'm glad I said that. She's the one who told me about the long bone, different from the craniofacial, the way the bones are grown, through a functional matrix. Like the eyeball is the functional matrix for the orbit. There's all kinds of sutures and things in there. Well, she called this the parallel facial sutural or fontanelle complex. We call these soft spots fontanelles. We have all over our face. And throughout human history, if they weren't being developed by ancestral patterns of nursing and weaning, and even like chewing and swallowing amniotic fluid in utero, these things start in utero, another area of research that we're pursuing. But you did not get out of childhood unless that's what was happening.
Mm-hmm.
So we are hardwired, genomically capable. Really, every kid who comes to you, you get them early enough and diagnose them right and get the right pressures and the myofunctional therapy and all those things work. And I'm still learning about this.
Mm-hmm. Me too.
Myofunctional therapy is key to all this. Chewing, getting kids, and I also do a talk on baby food. It's like, are you kidding? When baby foods were invented in the early 1900s near my hometown of Muskegon, Michigan, Gerber, that's the home of Gerber and Fremont, but it was advertised for invalids and infants. Invalids,
Mm.
like senior citizens, soft baby food. And rationing during World War II, that wasn't ration. You could buy as much baby food as you wanted. So people were putting it in, and adults were eating it just because it was cheap and tasty. Loaded with sugar and salt, by the way.
Yep.
The original baby-led weaning and baby foods, Clara Davis, Google her, Clara Davis, MD, at Children's Memorial Hospital, came up with the first randomized trial, prospective, of babies will choose healthy food if you give it to them and don't add sugar to it. I just sent that to Robert Lustig. He's another person you should get on here. I don't know if you've heard of him, pediatric endocrinologist at University of California at San Francisco.
I haven't, but I'll definitely.
But he's written the book on sugar, and he and I collaborate and lecture together. He's actually on the dental circuit now. He lectures a lot.
Oh, interesting. Okay.
So anyway, I probably went overboard there, but it really is. I like to talk about, look, we're not only hardwired as kids to want to please adult caregivers and elders, we are hardwired to really have the capability of epigenetically producing a beautiful craniofacial, what did she call it? She called it a palatal-facial sutural complex. And it's the tongue in the food that develops it from birth, and then lifelong commitment to eating fresh, firm, fibrous food.
And there is tons of literature out there that talks about the impact of the two things you said: diet, soft diets. I mean, Corcini is kind of the leader in that, and who was he? Was it Beecher? He had a bunch of studies with Beecher. They had one in '81 in Anglo Orthodontist talking about
Sim Wallace is another one.
Sim Wallace, yes.
Sim Wallace from England.
This is all there, and there are a lot of articles that substantiate that if you don't have enough mastication and masticatory force, then you have a higher likelihood of crowding, maleruption, narrow arches, retrognathia. And there's also, I mean, from the airway being the other matrix that you were referencing. I mean, look at, there so many people talk about Harvard studies and, with the monkeys and his rhesus monkeys. I mean, he had amazing studies, again, published in the orthodontic literature. Some of this stuff is in the medical literature, so we don't get it, but this is clear. So that, when you take away that matrix of airflow in these purebred rhesus monkeys, you get restricted development of the midface. You get higher vaulted palates, you get narrow arches, you get dental crowding. So you can't debate that. And I rarely hear, when I talk about this or debate this or have a discussion on this, you rarely hear people say that that's not true, because it is. Where they come to it is say, yeah, but we shouldn't do it earlier, right? But that doesn't mean that we start earlier. Well, my question to that is, why not? Because I saw that as I started going earlier and earlier, which I, again, wasn't trained to do, and I came out of my residency maybe treating a couple phase 1 patients, and they were all like 9, patients that you said in your practice are geriatric. They were sort of up to the mid to late mixed dentition. I noticed the earlier I got at it, and Stacy Becker and I have talked about Mariana saying juicy, and I love that. The earlier I got at these patients, the more I noticed how easy it was to move the bone and the teeth, and how tolerant these patients were of it. And then when you do it the right way, which goes beyond the scope of today to get into the exact technique, but how much they were able to, how well they grew afterwards, and how well the teeth came in afterwards once you normalized all of these things. So couple summary points I want to make on that. I think a lot of people hear this and hear what we do and what we talk about and say, you guys are treating airway and you guys are, overstepping, or if you wanted to do that, be a physician. And I think it's really important to clarify, and I want to hear your thoughts on this. We're not treating airway. We're treating the patient. We're recognizing issues in our patient, that it is our responsibility. And the ADA in their 2017 position paper said this very clearly. It is incumbent upon all dental providers to look for these things. How is this patient growing? How are they breathing? Understand what is happening in these patients. They didn't put an age on it. They didn't put once they reach X years old, they said it's our responsibility to screen for this and then refer to and work with the appropriate medical professionals as needed and perform evidence-based treatment to correct any deficiencies we see. Well, when I see a kid that's, let's just even say 6, right? Just so we don't get people to say, oh, you can't treat earlier. Let's just call it 6. Or I'll tell you what, let's even go with the AAO's stance of 7, which we'll come back to in a minute on that. But let's just go with 7, right? When you see a 7-year-old patient, because there's 2 things we're talking about. One is the concept of treating kids even younger than that, which that's a whole nother level that people reject. And the other is that you even do anything at 7, right? There's a lot of people who, if they don't have a crossbite, I mean, in the orthodontic arena, it is still taught to the majority of residents out there that if there is not a crossbite, posterior anterior crossbite at 7 years old, you don't do anything with this child. And I always use the example. I tell the residents, I say, well, if you give me a patient A whose maxilla is, this given width, right? And they have a posterior crossbite. Let's call it bilateral so we can take the whole CRCO shift conversation out of it and that TMJ and all that. So let's just call it a bilateral posterior crossbite and their maxilla is X width, right? You give me patient B that doesn't have a bilateral posterior crossbite, but has the same X width maxilla, right? That patient has a more severe malocclusion because they have a problem in 2 arches. Patient A only had a problem in 1 arch. Yet orthodontists all day long will go in and treat patient A, and they look at patient B, and I know for a fact, directors of programs and in residencies, they are teaching the residents you never treat a patient in the absence of a posterior crossbite.
I would guide your listeners to a 3.5-minute video by Sean Carlson, San Francisco visionary orthodontist.
Oh, Sean's great.
Harvard trained Sean Carlson. And he gives a beautiful explanation of a 2-part evidence-based study from Boston University, Leslie Will, Mila Motro. You do not need a posterior crossbite. Because
I'll reach out to Sean to get that. I appreciate you mentioning that.
If you upright the lower posterior teeth,
you have the crossbite.
100% of the time. And Carlson, he shows this and he quotes the study. He shows the data from it. So anyway, good for you for mentioning that. I'm sorry, I didn't mean to interrupt you.
No, please. I'm glad you mentioned that. I'll link that.
Sean is very generous with his, I call him Sean, like Sean Connery, Sean. But anyway,
it's a brilliant guy.
So I'm sorry, I didn't want to interrupt. So keep going because I'm fascinated with what you're saying right now.
So you take those 2 patients, and the fact that they tell you not to treat patient B, but treat patient A, it's completely illogical. So my overall point is, if people are saying you shouldn't be doing this younger, I literally heard someone on a podcast, an orthodontic colleague, say, if any lawyers are listening, when people go in and treating younger than the AAO recommends at 7, I think they really need to think hard about this. And I almost fell off my chair. I was like, what? Because what we're doing is still evidence-based. I'm just treating a malocclusion. I'm just treating a transverse deficiency. Last time I checked, there's no scientific law that tells me when I can and can't or should or shouldn't start this. As long as I'm upfront with the patient and the parent, in this case, the parent, provide the appropriate informed consent, explain and educate on what I'm doing and why, show me where that's overtreatment, mistreatment, malpractice, et cetera. And then the other thing that I'm just so miffed by and I can't seem to understand, and I do think it goes back to, as you mentioned, the great episode with Stacey Becker on her ASAP podcast with fear. I think a lot of it goes to the fear, right? I'm not comfortable treating that patient younger, so I don't want you doing it. And because otherwise, what is the argument for not helping this kid young? And as you do help them young, yes, many times when you help them grow and you normalize the transverse and you get them to our colleagues in the oral myofunctional arena, medical arena, allergy, ENT, you see this kid transform in front of your very eyes. And I say all the time to people, it only takes once. Once you see this happen on one kiddo,
you'll never be the same.
It changes you. It changes you. And I feel for all those who refuse to acknowledge that and see that, because I really do. I'm sad for them because it straightening. I always say all the time, straightening teeth is great, and I create a lot of beautiful smiles. And I love seeing patients of mine post on social media, and they're older and grown, and picture. I love it, but nothing will hit you to your core like when you detect these issues on a younger kiddo, get them the treatment and the direction that they need to go in with their medical colleagues, develop those arches, and you have a mom break down in tears in front of you and say, you are the only one who listened. You are the only one who took the time to try to figure out what was wrong with my child. And I have a different kid because of you. And one time that happens, and I guarantee it'll change you. Have you heard about the Doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off Doc educational materials. Just go to Facebook and search for the Doc community and submit a request to join the group. And now back to the podcast.
Well, and you brought up a mom, and that's one thing that when you're in pediatric healthcare, whether medicine, dentistry, whatever, your initial encounters and usually sustained is with the female adult caregiver. It's a mom or a nanny or an aunt or a grandma, big sister, whatever. And I really like to bring out the difference in instinct. I usually apologize if dad's there, no offense, but we got a Y chromosome and it gets in the way. And I've had so many female adult caregivers literally stamp their foot. I thought so. I'll show them.
Yes.
I mean, I go over the x-ray with everybody. I treat really parents like they're my residents because they're going to have to defend themselves.
Yes.
At Thanksgiving because Uncle Harry's an orthodontist and thinks I'm a quack, or whatever. And they have to defend their decision to the other parent or their own mind. We're going to spend money on this and put our kid, through months and starting them at 4 and they're done at 15.
Yeah.
Because they get Invisalign when they're, I just, you have to manage expectations. Mm-hmm. And I just really like to always, show everybody what I see. And I mean, I'll even say to parents, if you assimilate what I just told you about this child's distance from the adenoid swelling to the posterior nasal spine and soft palate, you understand more than most orthodontists and dentists and ENTs do about the sagittal depth of the bony nasal pharynx. That's from
Linda Anderson, right? Linda,
yep,
is that
bingo?
Yep.
But and I'm so I and people, they feel so respected.
Yes.
I'm going to spend
and heard and listened to.
And guess what? This won't change. And right now, Mike, you'll love this. A couple years ago, I got paired with a very interested pediatric oriented, if you will, oral and maxillofacial radiologist at Beam Readers. And he was sort of given over so he could spend time with me to develop my early childhood analysis.
Oh, neat.
Or because I have more files on record, I think probably at Beam Readers on kids under 6 than anyone in the world. I huge database. Well, now I just got called up, by Hatcher, Corey Hatcher, who's, in charge of something at Beam Readers. I think his father invented it, but they're getting ready to put my early childhood analysis into AI.
Oh, wow.
You can, if you submit to Beam Readers, you can ask, it's an add-on, but and what we were just talking about, Carlson, of measuring at the bone for transverse deficiency, not at the teeth. They will do all that. And now I'm showing them how on a frontal ceph, you can measure the distance between the unerupted upper first bicuspid, the mesial surface, distal surface of the erupted or unerupted lateral. That distance does not appreciably change in a transverse dimension after 5 years old. It just doesn't. And there's disparate places in the literature that show that.
Which is why if people say, well, wait, that can't be. But that's why you either end up having to extract or expand on these patients because it doesn't just self-resolve. When you get that significant deficiency in that dimension and you see it in these patients at 5, 6, 7 years old, it doesn't self-resolve. We do this watchful waiting, but what you're really doing is just trying to delay and bide your time so that you don't have to make the decision that you're going to ultimately make, which is probably end up pulling teeth on this kid.
Before I started working with Nick Schuff, who really does most of my analyses now, but Francisco Arasso and some others are really good I've heard about. But I've had some of my reports say, well, the distance between the unerupted, lateral incisor, maxillary incisor, and first bicuspid, the permanent canines will not have sufficient space to erupt ideally, or, they may erupt, or it's not necessarily going to be impacted. But, some of them will put that on there and others won't. And so Nick, was one who, well, I don't know, can you give me evidence to show that? Well, not of a prospective randomized trial, but retrospectively, I've got kids who have come in for treatment at 4 or 5, and I've got a Panorex, and I have lectured at the ADA Airway Symposium twice now, radiation safety for children. It's less than 7 microsieverts.
Mm-hmm.
Standard Panorex, a cone beam is taken on a certain machines. But I show kids that for whatever reason, didn't get treatment. And that is sort of a control that you can use. I mean, the paper that Audrey Yoon led at Stanford that showed that maxillary expansion can result in normalization of adenoid tissue.
The one in sleep, right? In 2022.
And they didn't have a prospective control group. You can't withhold a therapeutic regimen for a kid for the purpose of getting a control group. It's unethical.
Thank you.
The Nazi war trial, the Nuremberg trials, that's where IRB comes from.
Mm-hmm.
But you can't do cruel human experiments. But there is evidence in the literature pre-World War II that shows that transverse and sagittal and vertical problems, they don't self-resolve. Mm-hmm. And a big study from Harvard, which I would love to share with you, by a guy named Silver. Anyway, it's out there. And it's getting better because beam readers is demanding from me, like the ADA was. It's vetted by the scientific, if you're going to get up there and talk about something, you have to have literature, not necessarily have a prospective randomized controlled trial, blinded nature, but you have to have pretty good controlled observational trials or retrospective trial. You have to have some evidence to support your hypothesis. And that's really what we're talking about here, Mike, is hypotheses.
But have you read Outlive with Peter Attia?
Oh, yeah, but I use his video because of lifespan and health span. This one?
Oh, yeah, I have not read that. Who's that? I'll have to get this. He's holding a book for those listening. It's Ultra Processed People.
Chris Van Tullochen. He and his identical twin British, they're pediatricians, and they perform experiments on themselves because they're identical twins. But he totally gets the importance of chewing. Yeah. There's something, and he here's another one. I don't want to, stop this without talking about this book,
which is circa
1953, the human masticatory apparatus.
Human masticatory apparatus. Okay.
And I found it, and I couldn't locate it anywhere. And it was introducing dental anthropology in the functional matrix without calling it that. It was before Melvin Moss, but it was, I found it at the American Dental Association. Huh. It actually had a library, number for it. And I called and I told them I wanted it. And they went up into the attic in the archives, whatever, and brought it down to me because it was on a restricted, and I'm in Chicago near the ADA.
Yeah. And
they said, Dr. Boyd, we know this book is going to a good home. You don't have to return it.
Oh, wow.
Gave me this book. So again, it's really hard to find. I want to get it. I don't know if it's in the public domain yet, but Mike, I'm going to see about getting you, at least the content of it. If I have Kinko's and get permission to print it or something, you will love this book.
Oh, I'm sure it's that. I love that because that's the evidence informed side, right?
It's unbelievable.
And the people say evidence based, but he talks about, and I've mentioned on the show before, but the medicine, 1.0 being Hippocrates and bloodletting, et cetera. And then 2.0 being what we are now, which is totally reactive, right? Everything is a treatment. It's not getting at the etiology. It's not getting at the cause. It's totally reactive. And I really put orthodontics square in that category. And then he talks about the need to get to evidence or to medicine 3.0, which is preventative, right? I mean, there was a statistic I saw the other day where I think it's $10,000 as of 2020 numbers per capita in the US is spent on treatment. And I think it's $300 is spent on preventative. So it is our trend in our society of healthcare to treat disease, treat symptoms rather than try to prevent them from occurring. And I really feel there needs to be this paradigm shift in orthodontics and references and books like you're talking about, and all these studies and literature that inform us, plus our cases. Atia talks a lot about that too. That all the things that push the limits come from the fringes, come from private practitioners who are doing this, or hospital physicians, whatever the case, but are doing this on patients, and they realize something, and then you start to look more into what can be done and run the appropriate studies. So I really feel we're at that crossroads with exactly what we're talking about today, that we're starting to see that pendulum shift a little bit, but it's not there. And one thing I want to bring up and hear your thoughts on, and because as we get progress, right, as we talk about this, then we just had the statement that came out in the past couple of months from the American Academy of Dental Sleep Medicine. And we were talking about that a little bit beforehand, and the general consensus. I can put a link in the show notes because it's good to talk about all sides. And what's happening is that no single monotherapy is going to, whether it's expansion or surgery or all these, mandibular advancement or all these different types of myofunctional therapy, all these different types of things alone aren't going to necessarily solve airway problems or obstructive sleep apnea or even sleep disordered breathing. But that's not really an evidence-informed discussion or decision, because you're isolating monotherapies, right? You're looking at one isolated approach. We know this is multifactorial. If you've done this or dealt with this, I don't know anybody who jumps into this as much as you or I have that is like, yeah, go do this and it'll solve all these problems. Absolutely not. This takes
even DNA surgery. I was an invited commentary to Journal of Clinical Sleep Medicine. One therapy, adenotonsillectomy. The title of my commentary was "A Century of Failure of Adenotonsillectomy to Completely Resolve Sleep Disordered Breathing in Children." And it was a commentary on an article that was written from Canada and about minor malocclusion. And I think, I think that was the subtitle of "Minor Malocclusions May Not Be So Minor." Because it just doesn't. It needs to be adjunctive. And you know who Peter Vig is, right?
Sure. Yeah.
Well, Peter Vig, was part of my, formative years in ortho and pedo. He was held at high esteem at the University of Iowa.
Mm-hmm.
And his wife, Catherine
Vig, she published quite a bit on even class 2 correction. Wasn't she in with some of the
cleft palate? But anyway, Mike, this is really important. That documentary that was critical and some unjustifiably and some justifiably of orthotropics and Mike Mew. It's called Open Wide.
Mm-hmm, sure.
Well, Peter Vig, was quoted, and he brought up what you brought up, is that orthodontists all the time are doing, procedures that don't have really any evidence to support that, this is what you should be doing in terms of correcting class 2 or class 3 or, pulling teeth or, whatever. It's just something that's accepted and we do them. And he felt, he used that to justify that, well, why orthodontists aren't adamantly criticizing the Mews was because they know darn well that they're also using protocols that don't necessarily have substantial evidence, to support it. Well, then later on in the video, listen to this verbatim. Peter Vig, there are no diseases that are associated with malocclusion. None. He says that. And I'm like, Peter, he's a legend, right?
Yeah.
What happens, people become legendary and they start to believe everything they say.
Yeah.
And it just, I have utmost respect for him in the history, but for him to say no association, comorbidity, people, I think in our realm, who we're talking to here, who's listening to this and all your other great podcasts, is that they have to get used to comfortable using the term morbidity and comorbidity. Mm-hmm. When I was a pedo resident, and I don't know if you had any of this, but we had to attend M&M conferences. You know, it wasn't chocolate covered candies or candy coated, it M&M, morbidity and mortality. Kids who died, right, because of treatment or maybe not treatment, or it was an unknown condition and the kid had malignant hyperthermia and died, from general anesthesia, or they suffered morbidity. They didn't die, but it's, there's a health problem. Well, we should start using the term morbidity, comorbidity. You can have renal disease and a broken arm. Those are comorbidities, right? They're not necessarily related, but they do impact one another. Okay? That's how we should be talking about malocclusion and sleep breathing disorders, is that they are commonly comorbid with one another. And oh my gosh, sometimes maybe it's coincidental, but what the heck? The malocclusion is not going to self-resolve, so I'm going to fix that.
Right.
And if it fixes other things, or if somebody comes to me, a mom will say, well, you know what? Is gluten intolerance related to sleep disordered breathing? And what I'll say is, you know what? I don't know if there's literature on that, but you know what a kid with gluten intolerance or whatever disease doesn't need is crappy sleep. Okay? And doesn't need, a palate where there's no room for the tongue. So I'm just gonna fix that part of it.
Yep.
Maybe some things, and then we can write an anecdotal case study paper on it.
Right.
But you don't have to answer these questions yes and no.
Hey everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode. What you said is so great, because one of the things that I say so often is stay in your lane. I'm not going and trying to do the job of the ENT or the allergist, or stay in your lane. We treat malocclusion, right? We treat malocclusion.
Jeff Rouse, I'm sure heard of, but he's one of my heroes. And, he always says it, just do dentistry.
Yeah.
I didn't say, do just dentistry. I said, just do dentistry. And you're probably going to really have impact on quality of life beyond what you even can imagine.
Yeah. And our area's dentistry is not just the teeth. Yeah. It's not just the teeth. It's the neck up. I mean, that is our area. I had Eric Plumas, who's an dual trained attorney and orthodontist, on my show back in the fall of 23. And he talked about, our area is literally from the neck up. Like, we have a responsibility to address that entire area. So when we just focus on the teeth, whether it be, someone who's a general practitioner, a primary care dentist, pediatric dentist, et cetera, or an orthodontist, I really feel that we are doing ourselves a disservice, because we can do so much more than that. And I think that gets into the fear thing as well, right? It's really easy. It makes again, I want to say this in a way that is overly critical, but it is true that it makes our days harder the more we focus on things outside of the teeth, right? Like, it makes our days harder. And to me, it makes them more wonderful. It makes them more gratifying. But I think it's really easy for people just to try to just say, let's just focus on the teeth. Look, I straighten teeth. I'm really good at that. I can do that. And the easiest time to kind of move adult teeth around and have to do it once is when the kid's an adolescent, right? Again, not whether that's the right thing to do or beneficial, but the easiest time to move the adult teeth is around that time period. So let's just wait, pull some teeth if we need to, let them come in and try to figure it out. But anybody who's practiced long enough and done some early treatment, and I think the other part is they don't necessarily understand how to do the early treatment the right way. Some of the studies saying early treatment's not effective or it's not stable. Look at those studies. There's no standardization on the type of treatment that was done, the type of retention that was done, the duration of treatment, the duration of retention. I mean, it's all over the map. But so there's not, if you know someone who does early treatment well, and once I figured out how to do early treatment really well, and in my case, I'm saying, like 6, 7-year-olds, it shouldn't take that long. It shouldn't be that complicated. And it should be really stable. And if you aren't getting that, then you don't know how to do it the right way. I'm sorry to say. And I think it becomes an education issue.
What you said, that's the domain of the ENT, the sleep and breathing. And it's like, my response has become, you're right. You are 100% right. That is the domain of the ENT or the respiratory therapist or the sleep doc. But it's also my domain. It's a shared domain. If
Yeah.
it's above the clavicles, it is in a shared domain.
Yeah.
And I hear Samantha Weaver, OMT, she and I both independently discovered that that this is what we talk about.
Mm-hmm.
Don't say, oh, you're wrong. No, you're right.
Mm-hmm.
I mean, it's the same. Yeah, similarly, like oh, you can't expand the mandible. You're right.
You're right. You're right. Yeah.
You,
Right.
you can't suturely expand the mandible
Right.
because there's no suture.
Right.
You can unwarp the alveolus, you can upright the
Yep.
posterior segments,
Yep.
whatever. Don't say you're wrong.
Right.
Don't debate. Let's have a conversation. You're
Yep.
right on
Yep.
it, but let's talk about it. Yeah, so I just I don't know. I every day, even like walking away from this conversation today, Mike, I've already got some other ideas on some
Me
problems
too.
that I'm struggling with in my practice. And I just I think I'm constantly trying to evolve new strategies for thinking about problems and collaborating on problems and sharing ideas. And I don't know.
How do we get there? There's such a stigma about treating phase one, treating early, and we don't get the training. And then the other thing I'll mention is I'm a big believer, and this is my theory, that the Saltzman Index, which came out in 1967, that's what makes a quote unquote handicapping malocclusion. And a lot
Yes.
of residency programs are positioned so that they treat a high percentage of their patients in underserved populations where patients are on Medicaid and the state is paying for their orthodontic treatment. And so most medical necessity is judged by this Saltzman Index. And when you score it, they don't score the primary teeth. So you don't count crowding or steep curve of Wilson or maxillary bone width in these younger kiddos. And so you get a kid who has no posterior crossbite, that patient B we were talking about before with the narrow maxilla and the compensated mandibular arch. They could have, 8-10 millimeters of crowding in each arch. As long as there's no posterior crossbite, you can't get approval to treat that patient from the state. And I think that's fed into part of this problem because the orthodontic clinics can't get the patients to treat.
Absolutely. And I mean, what I'd like to say is IOTN, Index of Orthodontic Treatment Need. There's several of them. There's one called ROMA, and it's for babies. It's for kids. It's not complete. I would love to have input and maybe updating it or revising it. But it's one of the things that I think is overlooked is that, well, why spend a whole lot of time developing an index of orthodontic treatment need for kids that you're never going to treat? And
That's a good point. I didn't think of it that way. Yeah.
It's just something that needs to be discussed.
Yeah.
And the other thing that what I'd like to, we're getting near the end of it, but I really wanted to get this in.
Please. Yeah. No, go ahead.
Well, there's two continuums, okay? The first one is what defines an epigenetic disease, or what we call a disease of civilization, if you will, if you put it into the context of anthropology and how long we've been around, is that it's first identifiable. If it's identifiable as, you put it in that rubric of this is a disease of industrialization, cultural industrialization, if you will. It's first preventive, okay? If you identify it and it's something, it can be prevented. Now, I'm not saying I'm preventing gross malocclusion that is going to be resolvable with extractions when they're older. I mean, from that aspect, I do prevent severity, complexity. I decrease complexity of subsequent inevitable treatment that, I meet a 4-year-old. How long is this? Well, I'm going to be with you till your kid's 15. Let's get to know each other. Now, it's not continuous treatment.
Sure.
I'm going to get in and get out, just like ophthalmology and fixes myopia, and you get a different prescription and set of glasses and, whatever. You treat it. Well, a disease of civilization or industrial disease is a Western disease. It's first preventable. If you don't get it while it's preventable, it's reversible, like type 2 diabetes. Okay, that's reversible. Okay. Third, it's controllable. with proper validated treatment, like metformin, like insulin, whatever. And fourth, it's potentially increasing morbidity and mortality, or what we call now shortened lifespan and shortened health span. How long you can stay healthy into old age? You get a kid breathing, and this is from the Dunedin study from following 1,037 children for over 50 years now. One of the things they noticed, Mike, is that if a child can exhibit, based on metrics, validated metrics for impulse control, they're going to live longer and they're going to stay healthier longer, health span, lifespan. It's hypothetical, but that is powerful evidence. And I can do papers on this and everything. So, they're after, they're first preventable, second reversible, third controllable, four impacting, health span, lifespan, or morbidity and mortality. So that's why it's important. Now, the other continuum that I want to talk about is what the continuum is with malocclusion. It follows the pattern of a industrial disease or a Western disease, disease of civilization, is that malocclusion is first preventable. It's second of all, either reversible. You can get in the primary dentition, you can get those spaces between the teeth. You can get those ridges out and developed. You can get the mid face forward. So I guess that's reversible. That's also treatment or controlling the disease. You can slow down its progress, but I never tell a parent we do these early things. It doesn't mean they won't. And another advantage of early treatment, Mike, you decrease the complexity of treatment need later. So I don't know. I think this has been a marvelous conversation. What else?
I agree. This has been absolutely awesome. I mean, I could literally go. I'm only stopping just respecting your time and our audience's time, but I could literally talk to you about this all day. Just some final thoughts on how we change this for the better going forward. How do we get our colleagues, especially my colleagues, my orthodontic colleagues, to be more open to the idea of treating kids younger? Again, the AAO says age 7. I've never found any evidence or data to substantiate why they use that number, but it's what people say. Like AAO says age 7, you shouldn't treat them before then. Okay, fine. Even when they see them at age 7, though, many people still don't know what to do with them or treat them. And they just literally are like, oh, well, we're just going to kind of watch you. The parents are like, but they said see you by 7. And so many orthodontists out there are like, well, yeah, but, we're going to kind of watch and wait. So we've talked a lot about why that is and what that looks like, but how do we change it? How do we, more than just, I know these conversations we're having help, the awareness, the discussions, talking at conferences, doing all this helps, but how do we really shift that paradigm to one that says, oh, no, proactive orthodontics / pediatric dentistry 3.0, to analogize Peter Attia, is where we need to be? How do we make that leap?
I say we start out by acknowledging a reality and putting people at ease. Is you don't really have to want to treat these kids, any more than, I want to treat TMJ. I don't, but I need to risk assess. You need to perform validated risk assessment, but you don't have to treat.
Great point.
And really the ADA now with 8 conferences on pediatric airway health and policy statements, and adults and kids, you can't ignore this any more than you can ignore screening for cancer. And I'm not equating the severity of malocclusion with cancer. I'm just saying the continuum is this: perform validated risk assessment. Okay. And well, how am I going to perform a risk assessment on a 4-year-old? Because the oldest kid I see in my office is 8 or 9, 10 years old. Well, you're treating the parents or grandparents of kids, and you can say, oh, I understand you just have a new 2-year-old grandchild or whatever. Do they snore? That grandparent in your chair may be the first person to make his daughter, mother of that snoring child, this is a problem. It's not cute.
That's a great point. Yeah.
It really is. You have an if you're a prosthodontist, you can be helping kids indirectly. So I say validated risk assessment is incumbent upon anybody whether you're treating directly children or not,
Mm-hmm.
of any age, is validated risk assessment on these kids, then definitive diagnosis with records,
Mm-hmm.
with, beam reader analysis, x-rays, models, photographs, whatever. So validated risk assessment, definitive diagnosis, then this is a biggie. Appropriate collaborative referrals.
Yes.
When to send to an ENT. And my personal, and Stacy and other people's sort of, okay, Kev, if you say so, but I don't live, I have to make these direct referrals. I like to involve the PCP, the primary care pediatrician. They may not know who you are and what you do. Oh, he's a dentist, he fills teeth. What does he know? Well, in Chicago, I'm on staff at a big tertiary care children's hospital, so people kind of know of our work. But I like to involve that pediatrician because I know that they didn't get this in their training
Mm-hmm.
any more than I got it in mine. I'll say, look, we have a mutual patient, and I'll write a letter, dear PCP, which I'm glad to share with you and put it on your own letterhead. Our mutual patient presented today with a malocclusion and also on the pediatric sleep questionnaire has 12 yeses.
Interesting. This is really, yeah.
Oh, it is so helpful. And, pediatricians really, or it's there's general practitioner family physicians who see kids and adults.
Because I kind of bypassed them because of the fact that early on, I tried to engage them, but I didn't do it the way you did. I love the way you did.
Because they're not going to.
I tried to call them and
they won't pick up your call. They won't.
And so I was just like, well, and then I was on the cleft craniofacial team. I was venting to the ENT. He's like, Mike, just send them right to me. But I missed that piece that, wait, I could have, instead of just going with them as the gatekeeper, I could have just involved them in it and started to educate them. That's an awesome, awesome idea. And I'd love to have that letter. I can put that up in the show notes.
If you send a letter, guess where it's got to go? In the patient's medical record. It has to go in that medical record.
Yeah.
So you're on record that I want to collaborate.
Yeah.
And, I happen to work with several ENTs at different, tertiary care pediatric hospitals in Chicago, but who do you like? Do you agree? I'm not referring to get their tonsils and adenoids out. I'm referring to have them evaluated because on the radiology report, it says, these tonsils and adenoids are enlarged and, there's a pseudocyst in the left maxillary sinus or, so right away, or an allergist, who do you like? Is there somebody, and I'm getting to know other primary care physicians and specialists by virtue of my wanting to collaborate.
Yeah, getting them on board. That's such I'm so glad you said that because
now all of a sudden they have another resource.
Like jumping them. Yeah.
So now they know who you are.
Yeah.
So that's a biggie for me.
That's a great point.
So again, validated risk assessment, definitive diagnosis, collaborative referrals appropriately involving the primary care physician.
Yep.
Then treatment planning.
Yep.
And then treatment execution. Mm-hmm. And then reevaluating, is this going well? Is this not going right? That's the sequence that things should follow for everybody. But that really sort of is the foundation of that is you don't have to treat.
Right.
You don't you want to treat.
Right. You can go through the initial part of what you just said and come up to the treatment part and say, I'm going to send you to so-and-so who likes to treat this younger kids because I actually like to treat more adults with clear aligners. So that's kind of my thing.
Forbid, you're an orthodontist, an RO, a real orthodontist. This is going to refer to an IO like me, an imposter orthodontist.
Right. We got to let the egos go.
Oh my God. What's that? I mean, there's an orthodontist who sent me the most beautiful case, a 4-year-old, class 3 history. Kev, I don't do this, but I know you do. And I said, can I show your letterhead? And he goes, nah, block out my name, but you can say this is from an RO because I love your work. And these people traveled, 3 hours to see me. And so I hope this veil will come off where orthodontists aren't reluctant to refer to non-orthodontists.
Yeah, yes.
It's changing. Things are changing, Mike, and you're doing it, man. I
Well,
mean, you're
thank you.
helping
You as
us. So,
well. You as well. I mean, I can't thank you enough for this time. And you probably don't want me to say this, but just to show everyone his dedication, Kevin's on vacation right now. And that's how dedicated
oh
he
yeah,
is. Is that he does this because he's so passionate about it. And you can just hear the passion in your voice and the excitement as we talk about this. And I could talk with you for hours on this topic. And I hope that the audience got to kind of just almost be a little fly on the wall between two people that are just extremely passionate about this topic, sharing ideas. And this is what needs to happen. We need to start to come together and collaborate and idea share. And it's not about, well, I do it this way, or you do it that way, or I'm good and you're bad. It's about the patient. And I hope that came through to everybody is we can really expand our reality a little bit and help these patients. And you've done that so many times, and your patients are blessed to be treated by you and all the people you've taught, and you've changed so many lives through this. And as I said in the beginning, your name just constantly comes up as somebody who's just such a leader in this area. So I thank you for that and acknowledge you for that. And I please keep fighting. Don't, yeah, you're a fighter, and I probably don't have to tell you that, but just, keep teaching, keep spreading it, keep pushing it. I will be there at your side. I'm someone who doesn't mind taking arrows, and I will stand up for what I feel is right, no matter what. And, I'll whatever help I can offer to you in any capacity going forward, don't hesitate to reach out.
thanks.
I'm happy to.
I really appreciate that. And please contact Lauren Gates and come to Florida to this. It's going to be a major roundtable event with Stanley Liu, and I just, I really hope you're there.
It sounds great. And with Stanley, I mentioned when we hopped on before we started the show too, he's now at Nova where I am, and just starting to see people start to come together and say, wait a minute, we can start to collaborate, and we have a lot to say, and we're not going to back down from this and let the establishment sort of overwhelm our message. So
I'm going to make a recommendation that sometimes Steve Carsonson, he's already planning the next ADA Pediatric Airway Health Conference. And if he asks for my recommendation, I want to recommend you and also Mike at Stony Brook. What's his last name?
Fred Ferguson.
Fred Ferguson.
Yeah.
Oh my gosh. I mean, he would be so great to talk about pediatric behavior guidance in this. So
I appreciate that.
Again, Steve might not. Well, I'll just send him my thoughts about that, because he's put together such wonderful faculties for this. And
he's great. Yeah, I've been trying to work with he and Jerry Simmons about getting a joint episode with the three of us, which has been challenging to get our schedules to coordinate to talk about some of the plans they're working up with some of the clinical trials they're looking to do and so forth. So I would love that.
Oh yeah, the Sleep Education Consortium of Jerry's.
Yep.
Is just amazing down in Houston. So you should be part of that too. So yeah, if you're working with Jerry, God, that's great.
Yeah.
Okay, well, gosh, have a great, and don't worry about me being on vacation. If I was a cat, I'd be purring right now. This is so appreciative of you, Mike. Thanks, man.
Well, thank you, Kev. I can't tell you how much I appreciate it and how much I thank you for sharing your knowledge also with my audience. And I know they took a lot away from this and really helped expand their knowledge in the arena. So thanks so much for all you do.
Great. Well, have a great week.
You as well. Yeah, enjoy your time.
To have a great week.
Yeah, absolutely. Enjoy your time with family.
Okay.
And thanks so much.
All right. Hey, I can't wait to meet you in person, man.
Yeah, same here. Absolutely.
Okay.
Take care.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.